Okay, we're going to go ahead and get started to stay on time here. And we'll also be recording this webinar and posting it online so that people can refer back to it. I know collecting nurses in particular is rather difficult. So welcome to the webinar about the Oregon State Medical Forensic Exam Form 2017. I'm Nicole Broder. I am a sexual assault nurse examiner and the SANE program coordinator for the Oregon Sexual Assault Task Force. So today we're going to be going through the latest form and both discussing some of the changes that were made to the exam form in this latest edition, as well as just covering a few documentation things in particular. And I'm also going to start off here by showing you the website just so you know where to get this form. So okay. So I know that some old versions of our website are still available online to be found by intrepid explorers. It keeps popping up as an issue, and unfortunately, we do not have complete control over the old website to completely take it down. So I just want to remind everyone that our current website is OregonSATF.org, and this is what it looks like. It looks all nice and new and pretty. If you're looking for forms such as the updated SANE exam form, you can go here to Programs and SANE Program. And then over here on the right-hand side, there's a link, Application Forms. And you have everything set up here that you might need. They're broken up into forms that you would typically need for certification and forms that you would typically need for recertification. And under both, you have the 2017 state exam form. It's also under the Resources tab for SANES. And this has a whole bunch of stuff. So this has, you can see here, the 2017 state exam form that we'll be talking about today, but also has sample consent forms, sample discharge instructions, some white papers by the Medical Forensics Subcommittee of the Sexual Assault Task Force, has the latest State of Oregon medical guidelines for sexual assault evaluations, and then some extra stuff like the HIV post-exposure prophylaxis discharge instructions that Bridget Montgomery, an Oregon SANE, was kind enough to put together. But today we're specifically going to be talking about the 2017 version of the Oregon Sexual Assault Medical Forensic Exam Form. And so we're just going to be going through this page by page. If you have any questions that I don't answer, feel free to ask them in the chat or under the questions tab of your little menu here for GoToWebinar. I'll try to keep an eye on that, and I will check it at the end as well. So just to start, page one here, one of the things that we did in the latest version of the state exam form was to add a section up here for the patient label. Sounds small, but what I was finding was that as these forms get copied and recopied, and there's no space for the patient label, sometimes some of our charting or some of the prompts for our chart we're getting covered up. So hopefully by just setting that aside as an official part of the page, we'll keep from losing that. Just as before, it starts off with the exam, date and time, the forensic examiner, and the facility. Always important to have that on your chart. But one thing that we added was the patient's preferred name and the patient's pronouns. We know that many people go by names that are not their birth name that may appear on their patient label, whether that's because of a nickname that they've always gone by or because they've transitioned or for many, many reasons. And so we do consider it best practice to just ask every one of your patients what they prefer to be called and what their pronouns are. This helps get out of the way. We're trying to make them feel comfortable. And so if they go by Lizzie instead of Elizabeth, that's an important thing to do. Just as before, date of assault and time are there. Of course, that's if the patient can relay to you the date of the assault or the time. Of course, with cases of memory lapse or other situations, sometimes drug facilitated, they may not have an exact time period to give you. And so what you can always do in this section is say, memory lapse reported from midnight to 5 a.m. by patient. Don't feel like you have to come up with an answer that maybe the patient can't give you. Just try to be as accurate as possible with what the patient is relaying to you. And then from that, you calculate the hours post-assault. And again, it's okay for that to be a time range if it's kind of uncertain. If the patient does want evidence collected, very important to put the kit number under this OSP Safe Kit Collected kit number section. Of course, we will always send the patient with the kit number that we collected as part of their discharge instructions. But we know that patients lose paperwork all the time. If they want to come back to this, weeks, months, years later, it's really important for us to have that kit number on the medical chart so that that can be pulled up if necessary. And then for all organ cases, even non-reporting, they should be given a case number. And so it's also very helpful to put that here on the chart under reporting case number, just as another identifier. And again, that's true for both assaults that are reported, but it should also be true for assaults that are not reported. There should be a case number or incident number assigned. And then medically screened per protocol. We always want the patient to be medically screened, to have someone lay eyes on them and be able to say that they are stable for our exam. Because of course, our exam, the forensic part always comes secondary to medical needs. So we want to make sure that's being taken care of. And then just the same reminders that have been on previous forms of the chart. You can collect oral swabs first, allowing the patient to eat and drink during the exam. And then for reported or suspected drug-facilitated sexual assault, collecting blood and urine ASAP. We will discuss that a little bit more when we get to the drug-facilitated sexual assault section of this exam form. And if HIV prophylaxis is being considered, that needs to be started within 72 hours in order to be effective. Okay, the mandatory reporting section has not changed, except that we've tried to make it a little clearer as far as, for example, serious physical injury or injury from a deadly weapon. In both those cases, only the injury must be reported. And so we tried to kind of pull that out and make that a little bit clearer. Both of those terms, by the way, do have very specific definitions in the law. So if you have questions about what constitutes a serious physical injury or injury from a deadly weapon, that's outside the scope of this webinar, but that is something you can look up in the statutes and actually have a very clear definition of what constitutes that. Of course, we have our age-related mandatory reports, and then disabled or mentally ill. That's kind of a spectrum, sometimes a gray area. Again, outside of the scope of this webinar to really dive into, but just as a rule of thumb, if the disability or mental illness is to the point that it makes the patient vulnerable, then that is a mandatory report. And then if it is a mandatory report, you want to include who it was reported to, who made the report, and the date and time of the report. You only need to fill out this mandatory reporting box checked yes section with the agency, made by, and date time if it is a mandatory report. If it's not a mandatory report and the patient decides to report anyway, that's totally fine. You don't need to fill that section out. If it has already been reported, but it is a mandatory report, it is still your job to make sure that that report was in fact made. And so I would recommend putting on here report made by, for example, the patient earlier today confirmed by Nicole Broder Sane with a phone call to Portland Police Bureau or whatever, just to make sure that you are doing your due diligence. And then this next section with advocates and interpreters, slightly different than what we had before. So with Senate Bill 795, it does require that an advocate is dispatched to the hospital for all sexual assault exams. That bill just strengthened the language of the personal representative bill that was already in place, saying that advocates could not be prevented from coming to the hospital for the patient. but it's good to be proactive and call the advocate and let them be the ones to explain their services so that the patient can then really make an informed consent about whether to accept or decline those services. So we've added a checkbox to show whether or not the advocate was called. And then you have a separate checkbox, which was already there before, about whether or not the advocate is in fact present for the exam. Perhaps you called them and they're stuck in traffic. Perhaps you called them and there are 7 other calls going on at the same time, and they're just unable to be there. This helps show that you, in fact, were compliant with the law and did try to call the advocate. Remember to include others present during the history and during the exam. And if someone's coming and going, just be clear about what parts they were there for. And of course, if an interpreter was used, you want to put their name as well as their interpreter number, whatever license or certification number they have, and the language that was being interpreted. And then since the time of the assault is pretty much the same, we have our checklist of activities that may affect evidence collection, such as changing clothes, brushing teeth, eating, drinking. So we've just included that there as before. Remember to include clothing description. And from the medical standpoint, it's really helpful to know that for the exam because, for example, the evidence that you would be collecting if someone's wearing a tank top and there's lots of aggressive handling going on will be, you'll be thinking of different things than if they have, for example, a long sleeve and jacket and the aggressive handling is going on above the clothing. So there really is a medical purpose for checking on all this stuff and is very helpful. And of course, the last bath and shower, finding out when that was and how many baths and showers since the assault is always important. And while we're on the first page, I just also want to remind people that it's best practice to not leave any of these lines blank. If there's something that's not applicable, if there's something that the patient doesn't remember, if there's something where you're asking the patient and you can't get a straight answer because maybe their mind is elsewhere, just indicate that on the form. You don't want to leave blanks because then when you look back on it, either from the medical point of view or maybe you're prepping for trial, you can't really know whether you addressed a certain question unless you made some sort of indication. And then, of course, initial the bottom right-hand corner of every page. Okay, so then page 2, report of incident, that is pretty much the same as before as well, but just as a reminder, it's best to capture as many details in quotations as possible when those details are relevant to your medical examination and or your evidence collection. So what I don't need is, a big long paragraph in quotation marks about how the patient went to Jimmy John's the previous night with their best friend, and then they saw Will Ferrell on TV and watched a funny movie. You really want to focus this on what led up to the assault, what does the patient recall and share as far as details of the assault, and anything immediately afterwards. And that includes physical acts, that includes things that the perpetrator says, things that the patient says about their emotional state. All of that is relevant to your medical exam because it affects your head-to-toe physical assessment of the patient. It affects your emotional and psychosocial assessment of the patient. It affects your safety planning and your discharging with the patient. And so keep those things in mind and just try to keep this area focused. Any area where you can't get things exactly in quotations, that's fine. You can absolutely paraphrase. I know I don't get quite everything in quotations, but be very clear about making sure that anything in quotation marks is in fact a direct quote from the patient, and anything that's paraphrased is not in quotation marks. And just be consistent there. Okay, so then page 3, as before, we're asking if the patient has undergone any recent medical, surgical, or gynecological procedures. Keep in mind that sometimes patients aren't entirely sure what's relevant, and so you may have to come back and fill that in. I've had patients go, oh no, nothing, and then as we get to the speculum exam, they tell me, oh yeah, and I had a total hysterectomy. Well, that's relevant to put here. It's not recent, but it is going to affect my physical exam and my evidence collection if I don't have a cervix to assess or to collect swabs from. So just make sure to be thorough there. The patient menstruating at time of assault, currently using contraception, currently pregnant, those I think are all very straightforward. And then here we have the consensual sexual contact question. Now, previously, that was just asked, when was the last consensual sexual contact? But in talking with the lab, what's really relevant is if there was sexual contact consensually within the last 5 days or 120 hours prior to your examination, because that's the time frame where you might expect to still find DNA from that consensual sexual encounter on the patient, in which case they need to get some rule out DNA. So you check yes or no, and then just like with the mandatory report section, you only need to fill out this next section titled if yes to consensual sexual contact within the last 5 days, if the answer was yes. But if the answer is yes, really important to fill this section out. Very, very, very important. The date and time of the last consensual contact, of course. And then if the patient is willing to share it with you, the name or names of their consensual sexual partner or partners within the last 5 days. This is especially important for non-reporting exams, but really it's important to ask with any patient who's had consensual sexual contact, because if that kit ends up being processed by the lab is going to need to get rule out DNA standards from the consensual partner. And if you keep in mind, the time frame for some of these, and again, if someone is not reporting and then decides later, with Melissa's Law, they have up to 60 years. And so the forensic laboratory needs to know who to get those standards from. And of course, this is just all with the patient's consent. So if they don't want to share this information, just write down patient declined. But important to ask, and you can explain to them the reasoning too. And then the type of sexual contact within the last 5 days, oral, vaginal, or anal, so that, again, the forensic laboratory has an idea of where this other DNA is most likely to be found. So that's a little change from before. And then the information pertaining to the assault is unchanged, the location of the assault, what kind of environment it was, and then drugs or alcohol prior to or after the assault, with an indication of what the patient took. Also unchanged is the assailant information, total number, assailant A, B, I don't know why that says I. Apparently I need to fix something. But anyway, A, B, and apparently I for now. It's still an indicator. It's still specific. So write down the name, the description, the relationship to the patient. Again, when you're getting that description, what you're looking for is information that's relevant to you from a medical forensic standpoint. So for example, while I am going to assess any patient thoroughly and individually, the injuries that I might expect to find from an assailant who is significantly larger and heavier than my patient will still be different than the injuries that I may expect to find from a smaller and lighter assailant. And if the patient has hair that's blonde, whereas my patient has hair that's black, I'm going to be on the lookout for blonde hairs. If they were wearing a red shirt, I might be looking for red fibers. So that's why this aspect is really important to our medical forensic exam. I feel like this is an area that is can walk the line, depending on how you approach it, of getting more investigatory than medical. And I just want to remind everyone that we are medical providers first. What we're providing is a medical service. And so make sure to look at it through that lens. And again, this is an area where if the patient isn't entirely sure, for example, maybe there's memory loss and they don't remember, anyone, or maybe they just remember one or two people but can't rule out the fact that there may have been others during the time of the memory loss. Just indicate that here. Be really clear, explain in a way that if you go back to this in a year or 2 years or 5 years, you remember what you asked and the answers that you got. And I apparently have some editing to do with that assailant eye. No one likes assailant eye. Okay, so then acts described by the patient. Again, this part is pretty much unchanged. Things that I want to point out here, we check for penetration of the mouth, the vagina, and the anus. Usually that's going to be a pretty straightforward yes or no, unless there was memory loss, in which case we do have the unknown option as well. We may encounter attempted penetrations, and those are important to explain. What was attempted, how far did it get? Things like that are really helpful. And an area that many people forget to check off is by assailant A, B, or C, or you can scratch that out and make it I. Because again, considering whose DNA is going to be in which area is really important here. Same with, did ejaculation occur? Yeah, most of this is pretty unchanged here. Using a condom, using lubrication, kissing, licking, spitting, making other oral contact, or touching the patient in any other way. Just a reminder that you, if you check yes to those options, you really want to clarify those on the lines to the right. Where were they kissed? Where did they spit on? Where was the patient touched? Things like that will inform your evidence collection. And then under weapons and force used, if you check yes for strangulation, or sometimes the patient will call it choking, or perhaps they were actually choked, then there is a strangulation assessment on the following page that you can fill out. Otherwise, just this is pretty straightforward here. So the strangulation assessment, really important to assess strangulation on all of your patients, every single one. A lot of patients don't understand the severity of strangulation, and so they may not think to mention it. Many won't understand the difference between strangulation and choking. In fact, you'll find that with many medical providers as well. So just as a quick refresher, choking is when there's an internal obstruction of the airway, like if someone's choking on food and it's obstructing that airway from the inside. Strangulation is when the obstruction is caused from the outside, and it can be an obstruction of the airway or the blood flow or both. And so that can be with hands, that can be with a ligature, that can be with pressure on the chest that's obstructing that airway. But it's important to be able to explain that to the patient in case they're getting confused with terminology. And as with everything, use the terminology that your patient is giving you, but make sure you understand what that means. So you do have the options up at the top. Patient denies strangulation occurred, and examiner assesses no signs or symptoms of strangulation. The strangulation assessment is never not applicable. You always want to, at the very minimum, be checking those two boxes, even if nothing occurred and you're not assessing anything. But if the patient does report strangulation, you have the same screening as in previous iterations of this exam form. And remember that the number one symptom of strangulation is memory loss. And if your patient is reporting memory loss, even if they have no memory of being strangled, they might have been strangled during the time period that they don't remember. So again, just to reinforce how important this assessment is. And then you have the same things as before as far as what the patient's description of the strangulation is, how long they think it occurred, the number of times, the methods, their description, and your follow-up checklist to show that you did your due diligence and made sure that this patient was safe. Not good enough to go, okay, you were strangled, I checked a box. You want to make sure that they are evaluated and that they have follow-up instructions, because that can be serious and life-threatening. And then now on the same page is the drug-facilitated sexual assault assessment. Again, it's never not applicable. You always want to perform this assessment, even if everything is no. So, as usual, our indications most common for drug-facilitated sexual assault are that the patient appears impaired or intoxicated, in which case make sure that you are delaying your exam until such time as they can provide informed consent. If the patient reports blackout or memory lapse, or if the patient has a concern that they were drugged and they say, I think that I was drugged. So you want to check for those things. And then if the patient did have a possible drug-facilitated sexual assault, and if they are consenting, you always, always want to collect both blood and urine. Now, if the patient tells you, you can collect my urine, but I'm not getting a poke, it's fine to collect just urine. But baseline, if the patient's consenting, you always want to get blood and urine. We do typically see the forensic laboratory use blood for blood alcohol level and urine for drug metabolites, but it's not really best practice for us to be making that determination of, oh, I'm only going to collect blood or I'm only going to collect urine, because it's possible that the patient was slipped things that they didn't realize, or maybe they were slipped things, after the memory loss had already come into place. So please collect both those things. We do know that many substances leave the system very quickly. Still, again, if the patient's consenting, err on the side of collecting, because the forensic laboratory, their capabilities are getting better all the time, and there are certain substances that can incapacitate a patient that can linger in their system. So leave it to the experts, aka our wonderful forensic scientists, and just collect both as long as the patient's consenting. Now, if you're not collecting blood or urine for a forensic purpose, but you're collecting it for lab tests at the hospital, that's fine. But you would check the no boxes here because this is just asking about blood and urine for the purposes of forensic evidence. Okay, and then here we get into our physical exam. This area is a little bit reorganized from previous charts. We responded to feedback that people wanted the chart to be in the order in which they typically did their exam, and so we made some changes to suit that. We also included a much longer space for the affect assessment, or the patient's behavior during the exam. This is a really important area to be assessing. Because it really paints a picture of the exam, and it also is basically a large part of our assessment of their emotional and psychological state. As a reminder, we want to avoid subjective interpretations of the patient's mood and behavior. It's not helpful to say patient was angry, patient was sad, because people express that in so many different ways. And A, it's not very descriptive for you to go back to later on, but also B, you might in fact be misinterpreting their behavior. We know that trauma responses vary wildly. We know that probably in our own lives as well as in our patients' lives. I know that my own reaction to very stressful situations is to laugh. And I would hate it if that ended up in a chart as, patient was carefree and laughing. I mean, they can say laughing, but like patient was carefree, not anxious. Like, no, actually the laughter is a sign of my anxiety. So to that end, we really want to describe objective behaviors. Is the patient crying? Are they laughing? Are they fiddling with a tissue in their hands? Are they pounding the edge of the bed? Are they looking away from you? Are they staring straight at you? Are there sentences, run on without a pause? Things like that are what's really helpful to capture here. So hopefully with some additional space, that also assists in that goal. And then for the physical assessment, we just broke things down a little differently. So you have your assessment of the head. The mouth was asked to be separate, but then we don't have separate things for like eyes and ears anymore. That's just part of the head. Neck and shoulders are put together. Chest and breasts are put together. Please make sure to assess all of these areas if the patient's consenting. And then abdomen, and then we've separated out left arm, right arm, back, left leg, right leg. So again, responding to feedback about what categories would be most helpful for people. And then you would describe and then, of course, use your diagrams for injuries. If the patient doesn't want you to assess a certain area, that of course is completely fine. But once again, just make sure to document that because you don't want to be left wondering, oh, did I look at their legs? And then immediately after that, we have the bodygram of the head and neck. And we chose some new bodygrams in order to make it a little bit more useful for what people wanted to chart. So, for example, there's the back of the head, there's the neck. That's really helpful with your strangulation assessments. And then you have the usual front view, right view, left view, and into the mouth here. You have your diagram key down below as far as labeling what you've found. You can use that here or on the injury log. And I do recommend that unless you really have very little injury, that you use the injury log for the actual descriptions instead of trying to scribble into the little in-between spaces of these bodygrams. It just gets really crowded otherwise, hard to look back on and hard to kind of piece apart. And then we have our bodygrams of the full body. And these are also different bodygrams than we had before. Most notably, you still have front and back, but then the side views have this running man position is what they call it, allowing you to chart on the arms as well as the side and the flank without it being confusing about like the arm used to be covering the side. So hopefully this helps out there. And we do have a little reminder at the top of all these bodygrams that physical findings should be noted on the bodygram that allows for the best visual representation. Duplication across bodygrams is not recommended, especially when you have lots of injury or perhaps injury that could look different from different perspectives. Choose the bodygram that you think provides the best representation and then just chart it there. Because what you don't want to do is introduce doubt to yourself, to other providers looking at this, to attorneys if this ends up going to court about what a certain injury actually looked like. And if you're duplicating injuries across bodygrams, there's a high likelihood that it won't look exactly the same from bodygram to bodygram. And so which one is more accurate? And so just choose the bodygram that works best for you and just make that as accurate as possible. That said, if you have an injury that really wraps around where you feel like you need more than one bodygram, of course, you're free to choose that at any time. Like with everything in our practice, there's not really one set way to do every single exam, but typically duplication is going to introduce lots of complications. And then people seem really excited about this, as am I. We have bodygrams for hands and feet now, so that if you do notice bruises, lacerations, areas of tenderness, you don't have to try and squeeze it on those little tiny bodygrams. We've pulled these apart. We found some great bodygrams, thank you, Patty Kenyon, that help show many different angles and should help you really show your assessment in good detail. And I forgot to mention, but we have that little box at the top of every bodygram page, no physical findings noted at this time. So if you're not seeing anything, you want to check that box. Once again, you don't want to just leave a page completely blank because, again, it introduces that question of did you actually assess it? And you don't want to be wondering that. So then moving on to the anogenital exam, which typically come after the full body if the patient's consenting. Again, same information, but broken out a little differently. What we've done here is for any type of genital anatomy, whether genital anatomy that is typically related to females, genital anatomy that's typically related to males, or some combinations such as with transitioning patients, with intersex patients, things like that. We combined all of the different anogenital parts that you would want to assess onto one page, so you don't have to be flipping back and forth, and especially if you have a trans patient or an intersex patient, that flipping back and forth can really make them feel like, oh, I'm not typical, this charting isn't really for me. And so this allows everything to be on one page, And I've had lots of questions from SANES saying, I don't really know how to properly, to accurately chart intersex or some transgenital anatomy. And I'm hoping that this will help that as well, because with it all together, it should be easier to say, this was noted in addition to this. So really just make this your own. If you need to write in notes, feel free to write in notes. As with the rest of this, just make sure it's clear. If you need to go back and look at it, just really clear what you saw, what you assessed. So we have all that here. And then as before, we have the bodygrams following. And same reasoning, we have the bodygrams that used to be differentiated out into male and female, we now have all together so that it's much easier to be accurate. And again, if you see anything, we have now labeled these bodygrams with letters so that everything can go on the injury log instead of having to try and squeeze it into these, the little white areas in between the diagrams. So hopefully that helps both with being patient-centered, but also with accuracy for our exams. The injury log is pretty much unchanged. Make sure you're identifying the injury number and the diagram letter. The key code is B for bruise, A for abrasion, those keys that were on the bodygrams. Photo, yes or no. One thing that we did do was specify that pain should be 0 to 10. We have seen a lot of charts where it just says pain, yes or no, and that's really not a complete pain assessment from a nursing standpoint. So 0 to 10 is recommended. If you have a patient who would rather use descriptors, such as mild or, very stabby, things like that, you can absolutely write that in as well. But hopefully that 0 to 10 reminds you that we want to do a thorough pain assessment on anything that we find. And then, of course, room for a description. If you have a patient with lots of injuries, you can absolutely copy this page. And what you would want to do is down at the bottom where it says page 12, you just put, page 12A, page 12B, or something to denote, what came first and to help keep it complete. That's also true for page 2, the narrative, the patient's narrative when you're taking their history. If there is a really complicated assault and you got lots of quotes that you think are really important, you can absolutely copy that page as well. But again, make sure that you're differentiating them. So in that case, it would be page 2A, page 2B, etc. Okay, now this area is, the information is pretty unchanged, but the format looks different. And that's for evidence collection. So with, we have the common things that you would want to collect: clothing, head hair, oral swabs, all of that kind of stuff. We've taken away the description of how to collect these things. Hopefully, if you're doing these exams, you should know that already. But also the forensic laboratory includes that really helpful sheet in each kit with a reminder. So maybe you just haven't collected head hair standards for a while. You can go back to that sheet that's included in the kit for a reminder. And then we've included just the bare minimum reminders here as well. So for example, clothing, we have a note that each item should be packaged in a separate paper bag. Make sure to label each one separately. For head hair standards, we have a reminder that it's 24 shed or pulled hairs. For oral swabs, we have a reminder that it's 4 swabs. For penile swabs, we have a reminder that it's 2 swabs, 1 damp followed by 1 dry. As a general reminder, mucous membranes are always going to be 4 swabs. That's the mouth, that's the vagina, and that's the rectum, the true rectum, not just the anus. And then for dry surfaces, like external skin, or if you're swabbing underwear that the patient is unwilling to give up, but you see you want to swab the gusset, that's always going to be 2 swabs, the 1 damp followed by the 1 dry. And so we've just pulled that apart here and given you a chance to check not obtained with a reason, because again, it's completely fine to not collect something if the patient doesn't want you to, or if it's not indicated. But you definitely want to indicate why it wasn't collected to show that it wasn't just oversight, and to help show your reasoning. So you have all that here. Now with the vaginal cervical swabs, we have made that its own combined category. So for those of you who remember the old exam forms, you'll remember that it used to be 4 vaginal swabs and 4 cervical swabs. And the forensic laboratory processes it all together now and has asked us to just collect 4 combined vaginal cervical swabs. And so if you're doing that with a speculum exam, you just want to be kind of getting both the cervix and the vagina. The posterior fornix is, of course, still an excellent place to collect from because it tends to store fluid. If the patient declines a speculum exam and you're doing blind vaginal swabs, that is also an option that you can check here. And in either case, it's just 4 swabs total. As a reminder, you can have the patient collect their own blind vaginal swabs. I would make a note just here right next to the blind vaginal swabs saying patient collected themselves or per patient, something like that. And as slides are no longer required, if you have the 2016 kits, you'll find that there are just no slides included anymore. If you're working with older kits, such as the 2014 kits or before, there will still be slides included in the kit, and you can just throw them away. We're not expected to do anything with them anymore. And so we've also removed any discussion of slides from this evidence collection piece. So no slides, woohoo! Just another reason to love our Oregon State Police Forensic Laboratory. So also kind of clarified the alternate light source because we had noticed the same thing being charted in very different ways on previous forms. We have a reminder here that Blue Max is preferred if available. Woods lamps just are not as effective. You can still use them if you have nothing else, but Blue Max fluoresces more wavelengths that we're interested in. And so if the exam is performed and you do get a positive fluorescence, so an area lights up, you have the opportunity to explain where you got the swabs from. If the exam was performed but nothing lit up, then you have a checkbox for that. And then if it was not performed or not applicable, you also have checkboxes there as well. And then we pulled apart, and mostly just as a reminder, but also hopefully to cut down on a little bit of handwriting for you all, because I know this is a long chart to write out, and I know I get cramps in my hands. I'm sure you do as well. We pulled apart swabs obtained for aggressive handling, swabs obtained for possible saliva, and swabs obtained for additional evidence. So aggressive handling, we included a reminder that that could include strangulation, physical force. It's forceful or prolonged skin-to-skin contact. And usually that only lasts 24 hours. I would always say err on the side of collecting if you think there's a reason to collect. And you can say where that was. So if the patient was strangled, of course, you would want those 2 swabs, one damp followed by one dry from the neck. If maybe their wrist was grabbed, collect from the wrist, things like that. Same with the possible saliva. You have a reminder of things to consider: biting, kissing, licking, etc. And so once again, you would just say where it was obtained from. And you're looking at the 2 swabs, one damp followed by one dry. And then in case you have other things, maybe you had 5 aggressive handling swabs, or maybe there was semen on the abdomen that you wanted to collect swabs for. You have option N down here, additional evidence, and you can say where and why. So abdomen for possible semen, or right thigh for aggressive handling, things like that. And with the photographs, we have the obtained by and with, so you do photographer and equipment, or not obtained with a reason. And if there are any notes about the photographs, if maybe the camera was acting up, or maybe the lighting wasn't good and you were trying to finagle something, you can make a little note here so that if you go back to those photographs, you can do so with the full context. And you may not have notes about your photographs, but we like to include a spot just to double check. The police department receipt of evidence is the same as before. So if you hand deliver or lock up the evidence, this gives you the chance to do the date and time and get that chain of custody signed off there. And then if you you always want to remember that these pages 1 through 15 should always be copied and put into the SafeKit envelope. Very helpful for our forensic scientists when they are running the evidence and when they're doing their testing to have our full notes. The FLIF, the Forensic Laboratory Information Form, is also critical to fill out. That is found in the kit envelope itself, and you always want to fill that out and return the top 2 copies to the kit. But if you're at all able, please include a copy of these pages 1 through 15 as well. It just provides a lot more information, a lot more context, and it's very useful for them as they are testing the evidence. You don't need to worry about if the patient is reporting or not, because that kit should only be opened if the patient is reporting. So don't worry about identifiers on there, just seal it into the kit, knowing that it will only be opened if the patient has decided to report. And then if you're also welcome if the patient is reporting to make a copy of these pages 1 through 15 to pass on to the detective. As long as the patient has signed a release of information to law enforcement, that's totally fine. What you don't want to share is this last page, page 16, because this is really just medical record. So it starts with the HIV risk assessment, and just like with the strangulation assessment and the drug-facilitated sexual assault assessment, you always want to perform this assessment. It's very important to give our patients all the chances and opportunities that they might need and to give them a chance to discuss their HIV risk and decide what they want to do about it. So we have a list of things that would put someone at higher risk for HIV transmission. If any of the answers are marked yes, please discuss it with your provider. You can also discuss it with one of the hotlines available, such as the OHSU or CDC HIV hotlines. And then you can have the discussion with the patient from there. But even if HIV meds are not available in your facility or something like that, you always want to do this assessment. It's thorough and it's best practice. Then we have the chance to share treatment. So this includes STI prophylaxis, pregnancy prophylaxis, vaccines, and other medications. So you have yes, and then a reminder to include the names and the dosages for all medications given. I know it can seem like double charting if it's also on the medical record online, like Epic. What I found is that I really like knowing that it's charted what my recommendations were in case something goes wrong down the line, because usually we have the most up-to-date CDC recommendations, and I want a record of that. This is especially important if you're turning in these exam forms for certification or for recertification, because the Oregon SANE Certification Commission only reviews the actual exam form and doesn't review consents, discharge instructions, or any other EMR records. This is your only way to show that you know those recommendations. So make sure to fill that out fully. And again, if no, then explain why. Was it not indicated? Did the patient decline? Were they maybe sent with a Flagyl prescription home instead because of recent alcohol use? Just include that in there so that you know that you did everything you were supposed to do. For HIV NPEP, if they're started on that, then there will be 2 medications that they're started on, usually Truvada and Isetris. And so you have 2 lines and a note about the date and time of the first dose so that their follow-up HIV care can refer back to this. And then the last area, but definitely not the least, very, very important, is the follow-up and referrals. So referral packet given, that's usually our set of discharge instructions. Advocacy, again, should always be involved, so put their name down. If you got the social worker involved or if they signed up for counseling through the SAVE Fund, you have an opportunity to check that box there. And then safety planning, you can say that was by the advocate or by you and the advocate combined or the social worker or whatever you need. But it's just a reminder to do that safety plan. It does our patients very little good if we take excellent care of them in the hospital or the facility or the clinic where they're at, and then don't address what's going to happen when they leave. So if the patient says that they're safe, you can write that in there. But if they don't feel safe, make sure that you are involved in the process of making them feel safe and giving them options. Advocates usually are the best people to lead that charge. That does not relieve us of responsibility to make sure that it happens. Ideally, it's all of us working together. And then practitioner follow-up. So are they going to follow up with Planned Parenthood? Are they going to follow up with Dr. Smith? Again, it's more of a reminder to talk about that with the patient and make sure that there's a plan in place and to show that you did have that discussion with the patient. But you have the little note at the bottom to not send this page to law enforcement or include it in the SafeKit envelope because, again, this is part of the medical record. So that kind of takes us through the exam form here. Usually what you're going to do is make sure that this gets to medical records to be scanned in, but different facilities have different protocols. So a reminder to check with your facility and make sure that you know what you all do. I'm going to check here and see if there are any questions in the chat or otherwise. And it doesn't look like it. So feel free to email me, Nicole at OregonSATF.org with any questions. I'm happy to answer them. You can also always call the technical assistance line 503-990-5556. FYI, if you call and I'm not immediately available and you leave a message, you will receive a call back from my personal cell phone, which is a 740 area code. So I like to let people know that so they don't think it's some weird spam caller, but I try to be timely with answering that. And then we will also email out CEU certificates within the next 48 hours to the email address that you signed up for this with. So if that is not the best place to send it to, again, you can send me an email with an address that's better, and I'm happy to do that. Otherwise, thank you all very much for attending today. I hope this was helpful. Like I said, we will get this up on the website as soon as we can. And so if you have colleagues who were interested or have expressed questions about the exam form, please feel free to tell them to check that out on the website when it's up, and hopefully they can make use of it as well. And thank you very much. Have an excellent day.